our human body, inside some hollow organs are there. Inside the hollow organ, according to the body mechanism, some passage and movement also is there. Some pathway inside is there. But due to any disease condition, normal pathway is not possible for the mechanism of an organ means we will make on hole and place the inside of the organ to the external atmosphere of our body. That is the ostomy. Ostomy is an artificial opening only. It's an artificial opening only. By a surgical procedure, we will make on opening. And as I told, placing the inside of the organ part externally to our body surface. Mainly temporary basis and the permanent basis, we will do the ostomy. Temporary means for a time period. Example, after a surgical procedure, that surgery site need a rest for some time. Suppose for that need, we will bypass the pathway by making as an ostomy. That's the temporary ostomy. After the time period, we again reconnect and we will again restart the normal pathway. Then permanent ostomy is also there. Permanent means due to the disease condition, permanent basis, we removing the part of that organ means we will make an ostomy and then their lifespan is going that pathway like through the ostomy only. That's the permanent ostomy. Mainly two types of ostomies are there, input ostomy and the output ostomy. Input ostomy means, as the word meaning only, for the input purpose. So to the inside of the body, anything need to give means for that the input ostomy we mainly using. Example, tracheostomy. Tracheostomy means making an ostomy in tracheal area for the purpose of getting or receiving the air from outside to the patient body. Then other examples are gastrostomy or feeding ileostomy for the feeding purpose also. Making an ostomy and we are giving the feeding content into the body. It's the input ostomy. Then output ostomy. Output ostomy means from the body to the outside anything need to collect means example colostomy or urostomy or ileostomy. Like these ostomies, we placing that ostomy or main purpose to collect the waste material from the body to outside. This one is the example for an output ostomy, colostomy. So first of all, we're moving to the colostomy. Colostomy means what? As like an ostomy, it's a surgical opening and we making the large intestine part through the opening, we placing it in the outside for the collecting the fecal matter and for the excretion of the fecal matter and flatus, mainly we doing. In colostomy, mainly normally surgically we doing. It's a part also I am telling already. You know, mainly our large intestine is a hollow organ, tube-like organ. It having 1.5 meter length or 5 feet length is there. This hollow organ mainly we dividing into 3 to 4 parts: ascending colon, transverse colon, descending colon, and a sigmoid colon. According to the colon parts, the colostomy making means the name will change, because colostomy in ascending part means ascending colostomy, vice versa, transverse colostomy, descending and sigmoid colostomies are there. Then this is a picture of the colostomy. This picture showing is the colostomy bag also. About the bag, we are going to discuss. Mainly after the colostomy preparation, the stomal area we placing on bag for collecting the fecal matter. So mainly we using two type of colostomy bags we mainly use. One piece method and two piece method. One piece method means with the bag, the face plate or that sticky part will connect it, and it's a single piece. In two-piece means faceplate separate and a connection bag separate. So two types of mainly we using the colostomy bags. It's an actual picture of the colostomy bag. It's this picture showing one-piece method of colostomy bag. Mainly, first picture showing it's a measuring gauge. Measuring gauge means one patient colostomy size will vary. Maybe one patient stomal size very much small, another patient means a little bit larger. So according to the size of the stoma for the patient, we will prepare the faceplate. So while purchasing the colostomy bag, with that we will get on measuring gauge. Measuring gauge having circle type on hole is there. Every hole according to that hole size on value will be we can see on nearest to the circle. So we need to place that hole, that measuring gauge on the stomal area. We need to identify which size is appropriate for this patient's stomal size. Then we need to fix the size. Then 1 to 2 mm, 1 or 2 millimeter bigger than the actual size of the stomal according to the measuring gauge. Then we need to mark it on the faceplate. Then we need to, according to the size, we need to cut by using a curved type of scissors. Curved size shape of scissor we recommend it because it's a little bit easier to cut. Then sharp edges in between the cutting area we can avoid by using this curved type of scissors. We can use for the cutting and preparing the stomal opening for the faceplate. Then, as like every procedure, we need to assess the stoma something. First one is the stomal edema. Because after the surgery, post-operative manner, we can expect the stomal edema. It's natural only. But if it is long-lasting, the edema means we need to very much careful about that. But normally the edema is normal only. Around 4 to 6 hours, the edema will be there like that manner only. But it will decrease after 2 days. Around 6 weeks. After the 6 weeks, it looks like a correct, accurate, normal stoma. It will be there. So that edema is naturally we can expect after the surgery. Then stomal prolapse and the bleeding. Stomal prolapse means if the stoma, after preparing the stoma, that surgical procedure, after a few period of time, that stoma will prolapsing or bulging to outside, because inside the colon part also the bulging and it will protrude outside. It maybe it will cause according to the if the patient is in between pulling any weight, or a highly obese patient means abdominal muscle became very much weak, that weight bearing time and coughing in between the any time may be the cause for the prolapse of the stoma to the outside. The colon part also bulging outside from inside of the colon area. Then sometimes bleeding also happen. Already the patient is taking any anticoagulant therapy, and suppose any accidental injury is happening means also there is a chance for the bleeding on the stomal area. Then parastomal hernia. Herniation means, bulging of the internal organ to the outside through the abdominal wall. So here we already did on colostomy. So the muscle layer of the abdominal, actually the abdominal muscle area already weak. The continuity of the muscle layer on the abdominal wall already it's lost due to the surgical procedure. So in some cases, inside the colon part of our large intestine may be stick around the stomal area, inside the abdominal wall. So this case also in between already the muscle layer of the abdomen is very much weak only. So pushing effect of the colon inside of the abdominal wall around the stomal area means it maybe will get the herniation of the peristomal around the stomal area, maybe herniating. So we can correct it by a herniorrhaphy, but while doing the procedure, we need to relocate the colostomy. We can't continue the same. So it's maybe it comes again, will happen again. Maybe the chance is there. Again, the herniation may will happen. So we can expect that by a herniorrhaphy surgical procedure, we can correct the peristomal hernia. Then this one is the retraction. Retraction means while maybe any cause of the contraction of the colon part inside, means it will feel on pushing effect inside from the stomal area. So if that causes the retraction. Retraction means normal colon only just pushing outside due to the pushing effect from the inside the colon by as like a contraction. So mainly 14% of the colostomy cases, this type of retraction is reporting nowadays. But in this retracted case only, normal faceplate fixed colostomy bag, it's not possible to use. So in these type of retraction cases, convex type of faceplate we need to use for the fixation of the colostomy bag and the colostomy irrigation. Then this one is the peristomal reaction. Peristomal reaction means peristomal area means the nearest area, surrounding area of the colostomy is the peristomal area. This peristomal reaction mainly happening because as we all know, through the colostomy, the fecal matter and oozing and other waste discharge also coming. These waste discharge continuously getting contact with this peristomal area means it will cause the peristomal reaction or skin excoriation and the skin irritation will happen. So these type of a peristomal reaction, if we can avoid by using the proper size of usage of proper size of a bag and the skin care, everything we need to do for avoiding the peristomal reaction. If it happen means we need to, some of the adequate measures we need to do. We're going to discuss in next slide. So first of all, I told for avoiding the peristomal excoriation, we need to do some skin care. What are all the things we will do in skin care? First one, wash with soap and water surrounding the area, not the stoma, peristomal area. We need to wash with the soap and water. Keep peristomal skin very clean and dry. As much as possible, we need to keep it very dry and clean after the cleaning. Then use correct size of bag. Already I told we need to ensure the size of the stoma by using the measuring gauge on the basal faceplate. Then we prepare the faceplate according to the size. While preparation time, before fixing the size, after the accurate size, we need to give 1 to 2 mm size bigger than the actual size. Not more than that much diameter we cannot select, and too much tight bag also we cannot select, because too much tight means it will irritate the stoma. Too much large means peristomal area, that much exposure will happen for to this much waste matter coming from the colostomy. So we need to use correct proper size of bag. Then empty the bag when it is mainly half or 3/4 of the portion of the bag is filled with fecal matter, means we need to evacuate it, we need to empty the bag, or otherwise it will come through the stomal area and continuously getting contact with the minute just ring type of peristomal area will be visible. That area continuously exposing with the waste matter means it will cause the peristomal excoriation. So we need to empty the bag in proper time. Then use cotton cloths for the cleaning the peristomal area. Then apply Karaya powder. Karaya powder means it's a natural thing only. Market it's commercially we can purchase it like a Karaya powder in bottle form, but it's a natural thing only. Karaya plant is there. From the Karaya plant only means this one is the Karaya plant. From the plant only preparing as a commercial basis we can purchase from outside. commercially we can get like this only, this form of karaya powder we can get from outside. So this karaya powder with egg white, from the egg white, mix it with the karaya powder, then we can apply in the peristomal area. It will be a thin film like surface we can prepare by applying this karaya powder with egg white. Then other thing, barrier cream. Already this cream we can purchase it. We will get along with the colostomy bag. So this barrier cream also we can use. Then zinc oxide also for the peristomal skin care we can use. Then we need to ensure and we need to educate the patient also, avoid the powder or any cream or any deodorant, anything, don't use directly to the peristomal area or stoma, because it may will irritate the stoma or peristomal skin will irritate. So avoiding the smell or bad smell, any patient, if suppose using this type of doing anything, means we need to educate them to avoid everything. Then some dietary pattern also need to maintain. First one, gas forming food need to avoid, because this colostomy means there is a no sphincter control, there is a no control. Whenever the bowel opening time, in between the any flatus is coming, means it will come through the colostomy. So in between this type of bad smell is coming, means it will irritate the patient and the surrounding people also. So mainly the gas forming food need to control or need to avoid. Then the spicy and the chili type of food they need to avoid, because it will cause the normal bowel pattern will be disturbed, or in between the bowel contraction everything will happen. So due to these reasons, for the bowel friendly type of food only patient need to take, avoid chili and spicy type of food. Then onion, cabbage, like gas forming food need to avoid by the patient. Then what are all the oil content or oil items already they are practicing for cooking the food only, they need to continue after the colostomy also, because suppose changing of the oil for the cooking means it will cause the bowel pattern of the patient, it will may cause the loose stool as like a diarrhea. So if a diarrhea is happening, means also, as like I said, there is a no sphincter control. Whenever the bowel movement is happening, means also that time every time the fecal matter will come out. So in between is loose stool means, or rather diarrhea means, it will more discomfort, making discomfort for the patient. In between they need to change the bag, or in between opening means it will hurt the patient. So we need to ensure that also. Then use high fiber diet also. Fluid intake also they need to increase, because as like diarrhea only, in between if the constipation is happening, means also it will more painful and more hurtful for the patient, because in between the constipation may will occur, means through the colostomy the management is little bit fear for the patient also. So we need to avoid the constipation. So use high fiber diet and increase fluid intake also in their diet. Then traveling time, already we know inside the colon part only, after the colostomy it's fixing in outside of the abdominal wall. So we need to protect the stomach. So we need to educate the patient while traveling, mainly in public transportation system. They are depending for the traveling means they need to carry one purse or any handbag they need to carry for just placing upon the stomal area, for avoiding the any accidental injury in between traveling time. Then extra collection bag also, if they are being in a long journey, means they need to carry extra bags also, because I told half or maximum 3/4 portion of the bag is filled with fecal matter, means in between they need to evacuate, they need to empty it. After maybe in traveling time, accidentally they are taking another type of food items. Maybe the bowel movement is a little bit rapid. According to the rapid movement of the bowel, in between, maybe the bowel opening, fecal matter also coming. So in their calculation, they are expecting within this time limit, this much only the bag will fill. But due to the journey, the bag filling time also will vary. So according to the bag emptying time, they need to empty. So they need to carry extra bag also while the traveling time. Then clothing, there is no restriction for the clothing for the patient. Comfortable dress item, anything they can use in as a clothing. Then there is sexual life. After the surgery, there is need to some support and advices also need to give. So any support system from any counselor needed means we can guide and we can support them to take guidance from their side also. Then encouragement at the counseling. All are same only. Anything they need means we can suggest them for their continue their life. Then bag care. So use, already I told, use correct size of bag only. Appropriate size bag only they need to use. Then after I told maximum 3/4, minimum on half to 3/4 of bag, a portion of the bag is filled with the fecal matter means they need to empty. Then we can clean and reuse the bag means we need to educate them to use soap and water for clean the bag. Then for an antioxidant effect for avoiding the foul smell in the bag, we can educate them to put some charcoal pieces inside the bag. It will prevent the foul smell because it's an antioxidant activities there. Then dry, if drying the bag means under the shade only they need to dry the bag. Under the direct sunlight, we don't promote them to dry the bag because in between over dryness or the sunlight, it may cause some cracks in the bags. So it will cause the leakage. So we need to educate them. Then in between the washing, brushing or stone washing, anything they are practicing means we need to avoid them. We need to educate them also, avoid the type of rough type of washing. That bag we need to avoid. Then this on case I'm just presenting. Mr. T, 45 years old, was diagnosed with carcinoma rectum and had undergone sigmoid colostomy 3 months ago. Around 3 months passed after surgery. He has been using disposable colostomy bag for bowel emptying. Now he is a management executive and finds it's very difficult to manage it by in between changing the bags. It's a little bit tough for him. So what option can we advise him as a palliative care doctor, nurse, as a nurse? Any idea from your side? I would like to get some output.
So please share your thoughts. If you have seen these kind of patients in your settings, and he had complaining of difficult to empty the bowel bag frequently. He is working as a management executive. So what do you suggest? Any other option or? Okay. To wear loose and comfortable clothes. Okay. Any other things? So his main complaints is frequent disposal of bowel fecal matters from the colostomy bag because he is working. Give proper teaching to him how to change the bag and take care of it. He knows everything, but he's very difficult to manage. To avoid food that causing loose stool or diarrhea. So here, nothing is no history of diarrhea or other problems. His diet plan is also clear. Yeah, he is taking good fiber containing diet. Reassure him about condition. Okay. So again, advise to take plenty of fluids. Okay. Thank you. Any other answers? Just think about any other options. Work from home. Okay, that is not possible. Okay. So tell him to take rest for some time. Okay. Any changes in, you can check any changes in size of the bag. Her bag size is also all set. Here is the main complaining is when when the bowel is moved, the fecal matters will be coming out, and that fecal matters is collected by a colostomy bag. When the colostomy bag is filled, he needs to go to the toilet and discard the fecal matters or change the colostomy bag. That is quite difficult for him because he is working as a management executive. Is there any alternate option for that? Okay, thank you. Thank you for your contributions.
Okay, thank you to all for your outputs. Mainly this patient, actually it's a managing executive official meeting in between already he having. Actually his complaint is he is very much well aware about the dietary pattern. What are all the things included in diet already he know. How he need to change the bag, in between how often he need to change, up to how much amount of quantity in this bag, how often need to empty, everything he know. But in between change bowel movement time, in between bag is filling, he need to empty. So it is very tough for him. According to the professionally, he need another option because it's in sick mode colostomy. So we can suggest another option. It's a colostomy irrigation. Colostomy irrigation means just flushing or cleaning. By using a water, we just flushing and cleaning all the colon. It's simply we can say it as a colostomy irrigation. Mainly the colostomy irrigation. Which type of colostomy we can do? Which type of colostomy? Already I told ascending, transverse, descending, sigmoid, four parts of the colon. As per the name, we are telling us a colostomies. So here already the patient is in sigmoid colostomy, so we can do the colostomy irrigation. If this patient was in a transverse colostomy, means it's not possible because in transverse area of the colon there is a liquid, fluid, acidic type of motion content will be there in the transverse colon. Already in the transverse colon, from their part only, adequate needed fluid content absorbed by the colon. So that transverse part or ascending part is not possible. If the patient is in sigmoid colon only, we can suggest the colostomy irrigation for the patient. The purpose to establish the regular bowel habit. As a bowel training, as a part of the rehabilitation, we also telling the to improve the bowel habit, we will do the bowel training. Here also, we can train the colon, that colostomy for re-establish the regular bowel habit. Then to clean the colon gas or mucus and feces. Already I told, whenever the bowel movement time, fecal matter, maybe mucus, maybe gas form, anything may will come outside. So we can clean all colon at a time with the irrigation. Then in between the bowel opening means it will cause the skin excoriation also. But here at a time we fully washing out, flushing out, irrigating the whole colon. So in between the motion content or fecal matter will not come. So for prevention of the skin excoriation, we can do. Then mainly the plain lukewarm water mainly be using for the colostomy irrigation. Then some instructions also we need to tell to the patient. First one, irrigation need to be continued lifelong. If you starting the irrigation for the patient means in their lifelong they need to follow, they need to practice the colostomy irrigation. Then after the surgery, post surgery, maximum 21 days need to for the preparation of the stoma. After the 21 days, we can educate them to do the habit formation. Then daily on fixed time, they need to do the irrigation because they need to train that colon according to the bowel movement. So after mainly we telling after the 1 hour of meal, they can do the colostomy irrigation. In fixed time, they need to do. This one is the diagrammatic representation, how the steps going on in colostomy irrigation. This picture, middle portion, that colored picture, you can see. First one is the hanging type of irrigation bag. In connection tubing also there, in between on clamp is there. By using the clamp, after filling that bag with the lukewarm water, the patient only can control the speed of the fluid, that water, by using the clamp. Then the tube, in end of the tube, one funnel type of structure is there. That tip only, that's a not sharp, that's a blunt surface. That tip of the tube with funnel only going to insert the stomal area. Before inserting the stomal area, one sleeve is there, lengthy sleeve. Both ends having opening. First opening we can tie it by surrounding the stoma. Then another opening we can place it in the toilet. Then we can irrigate them, and that irrigated fecal matter will come outside through the sleeve.
We have a small video on that. We'll share on that, and after that we'll discuss on tracheostomy. Let me share that video.
Removal of fecal matter from the large bowel or colon. Colostomy care is the maintenance of hygiene by cleaning of colostomy bag and cleaning of colostomy sites. Articles required: colostomy bag with base plate or wafer 1, gauze pieces or cotton cloth pieces, 1 bowl with clean water, measuring guide, 1 curved scissors, a pen, 2 pair clean gloves, and 1 kidney tray. Procedure: greet the patient, explain the procedure to the patient and take consent. Provide privacy. Wash your hands and wear clean gloves. Always keep a fresh colostomy bag and accessories ready before the procedure. For daily colostomy care, first empty the colostomy bag. Remove the colostomy bag slowly by unlocking the lock of the colostomy bag to the wafer. The soiled colostomy bag can be reused after proper cleaning and drying. Clean the stoma thoroughly with clean water. Assess the appearance of stoma for any unusual color, size, shape, or uncontrolled bleeding. A moist pink reddish stoma is considered as normal. Change soiled gloves and wear clean gloves. Then attach a fresh colostomy bag onto the wafer. Press them together, beginning at the bottom and circling around the top side of the wafer. Colostomy bag has a locking mechanism. A click sound signals locking of the bag to the wafer. If there is a need to change the base plate or wafer, start removing beginning at the top while keeping the abdominal skin taut. If there is any resistance felt, use warm water to facilitate removal. Then clean the peristomal skin thoroughly with clean water and dry the area by patting with a gauze piece or cotton cloth piece. It is important that the skin surrounding the stoma is completely dry before putting the new appliance. Assess the appearance of peristomal skin for redness and excoriation. Measure your stoma with a measuring guide and select the appropriate size. Here, the size is 32 millimeters. Trace 3 to 4 millimeters bigger than the correct size onto the back of the wafer with the starter hole in the middle with a pen. Here, it is 35 millimeters. Cut the base plate or wafer along the trace. Remove the protective paper from the wafer or base plate without touching the adhesive surface. Apply the entire base plate or wafer over the stoma. Make sure the stoma is in the center of the hole. Press the wafer from the center to the edge and around the stoma for 1 minute to help it get a good seal. Then attach a fresh colostomy bag onto the wafer. Remove gloves. Ensure the patient is comfortable. Wash hands and document the procedure. This finishes the procedure for colostomy care. Take-home message. While applying a new base plate or wafer, it should be done in the sitting position for good approximation with the abdominal skin. Stoma side should be always dry. Presence of moisture increases the chances for candida infection. Always use a colostomy bag with the right size opening and change it at regular intervals. If the opening size is small, the edges will irritate the stomal mucosa. If the opening size is large, the bowel contents will irritate the peristomal skin, causing excoriation. If there is any excoriation of the surrounding skin, clean with normal saline and apply barrier cream or karaya powder. While cleaning, some bleeding is normal when touching stoma, but report to the medical team if there is any unusual color, size, shape, or uncontrolled bleeding. Close the outlet of the colostomy bag before fixing it to the base plate or wafer. Make sure the colostomy bag is attached to the base plate or wafer correctly. During bath, the colostomy appliance can be protected with a plastic cover. On the day the base plate or wafer is removed, patients can wash the area thoroughly with soap and water and pat and dry the area with a soft cotton cloth before fitting in a new appliance. Always empty the colostomy bag when half to 3/4 full.
Thank you. I hope it's clear to everyone on the colostomy care. If you have any further doubts or any clarification regarding that, please put your questions in the chat box. After that, we will discuss it.
Next we can move to the tracheostomy. Tracheostomy is an example for the input ostomy. Already we discussed colostomy as an example for the output. This one is the input ostomy. Tracheostomy is an artificially by surgical procedure we making an artificial opening in the trachea and we placing on a tube and fixing it there with the support of ties and maintaining on patent airway for the patient. Normally by nostril, if the patient is unable to take to respirate, means we can do this tracheostomy and help for the respiration. This one is the part of a tracheostomy tubes. First one is the steel type. Second one is the plastic type. Both tube having the outer cannula and the inner cannula will be there. In tracheostomy tubing parts, inner cannula tube length is lengthier than the outer cannula. Why? Why the inner tube is lengthier than the outer tube in tracheostomy? Any idea?
So please put your thoughts in the chat box. Here is the inner cannula and outer cannula and obturator. There are 3 parts. And when you look into the inner cannula is longer than the outer tube. So what is the reason for that? Any idea? So we are waiting for your answers. So Jafar said to secure the airway.
Prevent the dislodgement.
Prevent the dislodgement. Okay. Because cannula gets blocked while removing the inner cannula, the blockage is open. Okay. Any other answers? Okay. Any other answers?
To maintain the to maintain a correct oxygen level in case of some dislodgement occur or not.
Okay. Thank you. So Sony said to avoid mucus block. Okay. So thank you for your answers. As Sony said, if the inner cannula, the outer cannula is inner cannula is less than the long, maybe the size is too short, that mucus will obstruct the airway, because if the inner cannula we can remove it and clean it any time. But if the inner cannula is longer than, why the inner cannula is longer than the outer tube is, the outer tube, the tube is remains that all the times will be there, no? So that time, that when the inner cannula is too short, there is a chance of that blockage of the outer cannula with the mucus. So that is why the inner cannula is bigger than, longer than the outer cannula, because of that only. So to prevent that blockage with mucus. So that is why that the inner cannula is longer than the outer tube. Okay, thank you.
Thank you, sister. Here on obturator also, obturator while putting the tracheostomy, while doing the procedure time, obturator actually we using as a guidance. For the pathway, for the guidance only, we using the obturator along with the outer cannula, because its a tip is not sharp, it's a blunt surface. So it's easier to find out the pathway without making an injury. So these are all the actual parts of the tracheostomy. Then already we discussed about this. Then proper cleaning in between, mainly the inner tube cleaning is very much mandatory in the mainly in the tracheostomy. So then only we can maintain the proper airway for the patient. So mainly outer tube will be there as like sister said, inner tube only we removing in between for the cleaning. So we need to train the patient by using a mirror. They can see the front part of the tracheostomy area, their own tracheostomy area. Then according to the tracheostomy tube setting, they need to unlock and they need to put outside the inner tube in between. Then after putting outside the inner tube, they can only clean in a running water, under a running water, outside and inside of the inner tube also need to clean under the running water. Then they can sterilize in boiling water around 5 to 10 minutes. They need to boil it. Then after final procedures like washing in a normal saline also they can do. Then after the washing, proper drying of the tube by shaking gently and fast and do proper drying, then only they reinsert that tube into the outer tube. Then outer tube, there is no need to change by or remove by the patient. So we don't promote the patient to change the ties. Ties you already know, already there two ties in two sides of the tracheostomy tube is there for fixing securely in the tracheostomy area. So that ties don't practice to change by the patient only. Then outer tube, what are all the things we need to do? Changing the tie, appropriate changing of the tie need to do. After placing a new tie and secure it, then only we can change the or remove the old tie. Without that, don't practice doing the old tie. Then we need to apply and fix the tube in position. Whenever the old tie is dirty means that we can change. After tying we need to ensure there is 1 finger gap will be there in between the tie and the neck. We need to ensure. Otherwise, if it will be too tight, means it will irritate the stomal area and it will cause the suffocation for the patient. So we need to ensure that. Then patient, already I told, changing the tie by the patient, we don't promote them. Then as like here also periostomal area, some skin care need to do. Clean the skin around the tracheostomy tube with the saline of the gauze. Because here in between the mucus or sputum or very much sweating type of patient means in between the stomal area, sweat and dirt will be collected. So it will cause the skin irritation for that area. So proper in between cleaning is very much needed. Then keep the skin around the tracheostomy tube and clean and dry. We need to maintain. Then Vaseline gauze is also helpful in between the tracheostomy and the skin. We need to place on Vaseline gauze. It will prevent the excoriation of the skin on that periostomal area. Then suction and humidification. Proper suctioning whenever it's needed means we can do the suction, but only doing by very gently, not more than 5 to 10 seconds. Maximum 5 to 10 seconds only at a time we need to suck doing the suctioning time, because we need to prevent the hypoxia. Long time, if we suctioning means patient will affect the hypoxia. So we need to avoid that. Then proper humidification also needed for avoiding the dry air. Dry air in between the patient is inhaling means it will irritating for the patient. So we need to place on wet saline gauze. We can place on the tracheostomy, and we can provide on humidified air inhalation for the patient. Then as a speech, normally in tracheostomy patient means they unable to speak with the tracheostomy, but we can train them to speak step by step by closing with 1 finger on the tracheostomy opening. So mainly the speech therapist only will do. We can also initially we can make them to start speech therapy as like close with 1 finger on the tracheostomy, and they can spell it by step.
So as Sajan said, tracheostomy is one of the important area in palliative care. So there are two different types of the tracheostomy tubes are available, portex tube and metal tubes. Usually the portex tube will be there for the temporary period. So if the patient is having a permanent, maybe after the period of time, if the tracheostomy is permanent, they will change from the portex tube to the metal tube. So here the cleaning procedure is also different. If the vortex tubes are there, you can change the inner tube anytime and clean under running water. And then after that, you can wash with normal saline and shake well and make sure that there is no water inside that tube, and then you can insert the inner cannula. That is about the vortex tube. But in case of metal tube, after cleaning, when you can remove the inner cannula and then you can wash under running water, and after that you have to boil it 5 to 10 minutes. So this is the metal tube. No, you can boil it, and after that you can wash with normal saline. Make sure that there is no water inside, and then you can insert it. And within 5 to 10 minutes, they have to reinsert the inner cannula. So you have to educate the patient. Otherwise, the outer tube will block with the mucus. So that important message you have to convey with the patients and the caregivers. And always you have to educate the patient about that, the tracheostomy care, and especially the inner tube changing. They can use the mirror and they can change the inner tube anytime and wash under running water and clean it, done, and then after that they can also put it, replace the inner tube. Okay, and also as Sajan said, speech therapy. So you have to educate them, at least 1 or 2 words they can speak it out. They can take a deep breath and close the tracheostomy area and speak few words. And then about humidification. Always you have to educate the patient about the stoma protector, at least a gauze piece wet with the saline or normal water, and squeeze out excess water and put it on the tracheostomy area. That will prevent the dust entry and insects entry, and also prevent infection also. So that will give some humidification effect also. So that if there is a dry cough is there, so we can avoid that also. So we have a video on that tracheostomy care video. I'll show that video, and then again, if you have any doubts on that, we will discuss it.
Tracheostomy care. A tracheostomy is an artificial opening made into the trachea into which a tube is inserted to establish and maintain a patent airway. Different types of tracheostomy tubes commonly used are portex tubes, metal tubes. Parts of a tracheostomy tube: outer tube and inner tube. Inner tube fits inside the outer tube. The inner tube is held in place by a small flip lock which is located on the top part of the outer tube. Articles required: a sterile tray containing sterile gauze pieces or sterile cotton cloth pieces, swab stick or cotton buds, a clean tray containing normal saline or homemade saline, clean scissors, 2 pairs clean gloves, 1 bowl, 1 stoma protector, cotton tracheostomy tie tapes or cotton cloth tape, cut piece of suction catheter or brush, 1 small towel and 1 kidney tray. Procedure: greet the patient, explain procedure and take consent. Provide privacy. Make the patient sit in a comfortable position. Wash your hands thoroughly with soap and water. Put on clean gloves. Place a small towel over the chest. First, unlock the lock and remove the inner tube by gently pulling it out towards you in line with its curvature. Then, wash the inner tube. Clean the lumen and entire tube thoroughly under running water. If thick secretions are there, soak the tube in normal saline for a few minutes and use a cut piece of suction catheter or brush for cleaning. Then, clean the tube with normal saline. Gently tap the tube after rinsing with normal saline and ensure that the lumen is clean and no water is left inside the tube. Now, replace the inner tube. Insert the tube by grasping the outer flange and inserting in the direction of its curvature. Lock the tube in place by pushing gently or turning the lock into position. Support the outer tube and remove the soiled gauze dressing around the stoma. Assess the condition of the stoma for redness, swelling, character of secretions, and bleeding. Change soiled gloves. Pour normal saline into the bowl. Wear clean gloves. Clean the flange of the outer tube with gauze soaked in normal saline. Then, clean around the stoma under the flange with a swab stick soaked in normal saline. Care should be taken not to allow the cleaning solution to enter the stoma while cleaning to prevent aspiration into the lungs. Make a small cut in the middle of the lower edge of a 4 x 4 cm gauze piece into V shape and place it under the flange of the tracheostomy tube and around the stoma as shown in the video. This ensures that the stomal skin is covered well. Ensure that the tracheostomy tube is securely supported while applying dressings. Change the tracheostomy ties. Tie is used to fix the outer tube in position. It should be changed by trained persons when the tie is dirty. Leave the soiled tape in place until the new one is placed to prevent accidental displacement of the outer tube. Roughly measure the length of the ties to be tied and cut to appropriate length. Apply the new tape. Tie the tape at the side of the neck. Ties should be tight enough to keep the tube securely in the stoma and loose enough to permit one finger to fit between the tape and the neck. Remove old tapes carefully. Place a wet stoma protector or netted cotton cloth squeezed off excess water over the tracheostomy tube. This helps in humidifying the inhaled air and filters the dust. Remove used articles. Remove used gloves. Ensure the patient is comfortable. Document the procedure. This finishes the procedure for tracheostomy care. Metal tracheostomy tubes are also available for use. The care is the same as shown in the video. After cleaning under running water, sterilize it by putting it in boiling water for 5 minutes. Then replace it. Points to remember. Train the patient to clean the tube by themselves using a mirror. The inner tube should be replaced within 5 to 10 minutes to prevent blockage of the outer tube by secretions. It is advisable to have an extra clean inner tube kept ready to be inserted when the soiled inner tube is removed for cleaning. Keep the stoma covered always to prevent entry of dust or flies. Do tracheostomy care at least once daily. Clean the inner tube 3 to 4 times daily to prevent the lumen of the tube getting blocked with secretions. Ensure that the lumen of the suction catheter piece used is clean and ready for next use.
Okay, thank you. Anybody have any doubts on that? Please ask. So we have one more video on colostomy irrigation. Sajan had discussed about colostomy irrigation. So I think this will help you. So I will share that video also, colostomy irrigation. This is not a final video, but you will get an idea about that.
Irrigation. Colostomy irrigation is a way to regulate bowel movements by emptying the colon at a scheduled time. The process involves infusing water into the colon through the stoma. This stimulates the colon to empty. Articles required. Colostomy irrigation set, which includes an irrigation bag for lukewarm water, tubing with a cone end. One end of the tubing is attached to the container and the cone end is inserted to the stoma, and a clamp. An irrigation sleeve and belt. The sleeve is a long, transparent plastic bag which is open at the top and bottom. The bottom portion is usually kept clamped. Bowl with plain water, xylocaine gel, clean gloves, 2 pairs, steel tray with gauze pieces or washcloth, lukewarm water 1000 ml, 1 kidney tray. Procedure. Greet the patient. Explain the procedure to the patient. Provide privacy. Provide a comfortable sitting position to the patient near a toilet. Wash hands and don gloves. Fill the irrigation bag. For this, first clamp the tubing of the irrigation bag. Then fill the irrigation bag with 1000 ml of lukewarm water. Open the clamp and allow the water to flow through the tubing. This removes air from the tubing. Reclamp the tubing to off position. Hang the irrigation bag at just the patient's shoulder's height. If the bag is kept higher, the water will flow faster, which will cause abdominal cramping. Remove the colostomy bag from the base plate. Clean the stoma with plain water using a washcloth or gauze. Lubricate the little finger with xylocaine jelly and insert it into the stoma. Note the angle of the stoma. This is how the irrigation cone should be inserted. Discard the used gloves and wear clean gloves. Attach an irrigation sleeve to the stoma. Gastrointestinal content is to be flown directly into the pan or commode. If not, clip the bottom of the bag with the irrigation clip. Lubricate the cone's tip liberally. Gently insert the cone into the stoma in the direction of the angle of the stoma. Use the regulator to allow the lukewarm water to go slowly into the stoma for 5 to 10 minutes. Observe the patient. If the patient becomes nauseous or experiences cramping, slow down the infusion or stop it. Ask the patient to take a breath and then restart when the discomfort subsides. When the irrigation bag is empty, stop the infusion, wait for 10 seconds and remove the cone. Wait for the return flow. It will take about 30 to 45 minutes for the contents to fully evacuate. When the content is fully expelled, dispose of the sleeve. Clean the area and replace it with a new colostomy bag. Remove used gloves and wash hands. Make sure the patient is comfortable. Document the procedure. This finishes the procedure for colostomy irrigation. Points to remember. Irrigate within 1 hour after having a meal or hot drink. The irrigation will take 1 to 1.5 hours. It is important that you never rush the irrigation. Never remove used gloves and wash hands. Make sure the patient is comfortable. Document the procedure. This finishes the procedure for colostomy irrigation. Points to remember. Irrigate within 1 hour after having a meal or hot drink. The irrigation will take 1 to 1.5 hours. It is important that you never rush the irrigation. Never force the cone tip into the stoma. It is important to irrigate at the same time each day to establish a routine and form a bowel habit. When the colostomy irrigation is done correctly and regularly, the colon gets trained to empty completely with no spillage in between during the day.
Thank you. Any doubts? So Priya is asking one question: after how many days you can change tracheostomy tube for children and adolescents? So we don't change the tracheostomy tube, but we can able to change the tracheostomy inner tube for adults, and anytime you can change it. If the secretion is too high, you can change it every maybe every half an hour or every hour, or depends upon the patient's secretions. But otherwise, at least 2 times a day, you can remove the inner tube and clean under running water and make sure that there is no secretions and or no water inside the tube and replace back. But we don't change the that in outer tube. If you have any problem, you can send the patient to the ENT specialist or anesthetist, and they will change the outer tube. Priya,
Yes, ma'am.
yeah,
But I have a child who's on tracheostomy tube, but every 15 days she have to go and change her tracheostomy tube, and we provide the tracheostomy tube for her.
are you talking about the outer tube or inner tube?
I don't know, the whole tube we give her, it costs around about 600 rupees. The family is very poor. So we buy it and give it to her. Every 15 days, she goes and changes it. And we can't change it, but she goes to the hospital and change it.
Okay, so I don't have the details about that. I don't know why it is happening like that. Let me check it with our the pediatrician and let you know. I will definitely check with one of our pediatrician and let you know. Okay.
Yes, ma'am. Thank you.
And one more question is there. How does trachea esophageal fistula occur? Who asked? Leela Kandi madam is asking that question. We don't know the exact cause. Mostly esophageal cancer patients can get, very rarely can get tracheoesophageal fistula, but we don't know the exact cause. Madam, are you talking about the management part or the cause?
The cause, because the patient whom I about to present also had that tracheal esophageal fistula, one of the complications. So I just wanted to know why it occurred.
Yeah, okay. So, okay. I have seen one patient when I was working as in a regional cancer center. So that time the patient, that patient diagnosed with CA esophagus, and we managed with the nasogastric tube. We put nasogastric tube, and we managed that way. But that patient died peacefully. But before that, he has lot of distress. But after that, his distress comes down and he died peacefully. Okay. So,
Ma'am,
yeah.
when patient is with the tracheostomy tube in hospital care, when we are using to do suction with a suction machine with suction tubes, how much length we have to insert to suction the secretions through the tracheostomy tube?
Oh, how much length?
Yes, ma'am. How much length we have to insert to remove the secretions?
Okay. Any idea? So I don't know the exact length. Let me check it and let you know.
Means if we will put little bit inside, means patient will continuously
I
get
know.
cough and all, the secretions will come and
Yeah, I know. We usually do it, but we don't know how much length is inserted and all. So exact length. So anybody have any idea on that? Otherwise, let me check it and let you know. Two questions are there. I will check it and share it in the group.
And if the secretions will become more tough, means what we have to do, madam, to liquefy that secretions?
You can use some mucus, maybe like a mucositic some medication. So you can that if the usually we use medications for that. We can and that if the mucus is too hard, it's very difficult to because cough will be there. So that time you can use some. We usually use what medication?
Normal saline we put. Sometimes we have to.
No, ma'am, we don't, we can't use normal saline for liquefying the secretions.
Okay.
We use some medications for that. Mucolite, we use mucolite for that. That time
Okay.
that mucus will become loose, and then we can able to you can take the liquefy the mucus with the suction.
In our practicing, we doing one thing also. Before suctioning, we'll do the nebulization. 15 to 20 minutes nebulization, then only we will do the suctioning. In between, if any irritating it's showing means we will do. Otherwise, the periodical suctioning we will do under the guidance of the nebulization also. Nebulization and just physio.
Yeah, if you do this nebulization also, the mucus will loose, no? And also physiotherapy. Just physiotherapy will helpful for that also. Also, you can think about the pharmacological agent also.
Okay. Thank you, ma'am.
Yeah, so Sony said mucum is nebulization. Yes, if you use some kind of that medications with nebulization that will help. Okay, so we can move on to the case presentation. Leela Kanti ma'am is waiting for that. Ma'am, so to you.
Next slide. Patient, he's 74 years old, male, diagnosed with CA larynx, and then he was came with complete heart block. Next slide. He had presenting complaints of fainting spells at home. He came with cough, chest pain, breathlessness, and malaise. Next slide. History of illness, like in 2018, he was diagnosed with cancer, CA larynx, and then tracheostomy, followed by radiotherapy was done. There was loss of speech, but he was very mobile. He was traveling abroad, and he was able to take care of his needs. And he was doing regular follow-up with the ENT team, but then after the COVID, then from 2020, he didn't come to the clinic. Next slide. Next slide. Hello. He was conscious and rational, but now bedbound because he was having these faintish attacks. And he was afebrile. His pulse was about 60 and BP was 110 and 70. He had cough. There was secretion from the tracheostomy, but also when he was taking oral fluid, there was leaking from the tracheostomy, which he said he didn't have at home when he was there. This was after we realized that. Yeah, next slide. So the routine investigations were done, WBC and hemoglobin was 1.5 and slight elevation of WB6. CRP was also a little high. Creatinine was 120. ECG showed complete heart block. Flexible laryngoscope was done, and then it was found that there was fibrous. It was fibrous and fistula was present. So we had to keep him nil oral and start NG feeds. And there was a plan to do PEG to give a gastrostomy, but that was not done. Next slide. Main medications were aspirin, was on aspirin, losartan, vitamin D, and injection was on injection augmentin, that's Clavamox, because of the infection. Next slide. Psychosocial aspects, because he's a retired soldier, and his spouse was about 74 years old. He was married. He had 2 married daughters and a son, and they were living separately. He was religious background. He was a Christian, and he was able to take care of himself, though he had lost his speech. But now was dependent, and the fear of being dependent was a burden to, and also that he will be a burden to the children. And he just denied that he cannot have oral feeds because now we couldn't give him. We had to start NG feeds, but he said he could. So that was a problem for him. Right now, he just couldn't accept that he has to go have NG feeds. Next slide. So the main concern was the risk of falls and his nutritional status, because he is a person who was doing everything by his own, like on his own. So it was difficult for him to think of being fed with an NG tube, and like to have an adjustment to restricted life, and also infection because of this fistula. Next slide. Summary: 74-year-old man with CA larynx with permanent tracheostomy. Complication was tracheal esophageal fistula, and then there was he has had a new thing. It was a complete heart block. Discussion points: maintaining nutritional status, preventing the risk of falls again, and also family support and tracheostomy care.
Thank you, ma'am, for the presentation. Anybody need any more clarification regarding this patient story? Please ask her. Otherwise, we can move on to the discussion points. Okay. So nobody's need Any more clarification regarding this patient story? I think this patient story is clear to everyone. We can move on to the discussion points. So please share your ideas. We need to help Leela Gandhi ma'am for helping this patient. Any idea? Now we learned about tracheostomy care. I think all of you have get a good idea about tracheostomy care. Any other points you want to discuss, you want to add? Please put in the chat box, or you can unmute yourself and talk. So the first question is how we can maintain his nutritional status. Anybody? Dietitian, okay, dietitian's advice. Okay, here she don't have a she doesn't have a dietitian. You can share your thoughts. You can just share your ideas. How can we manage? Fiber, nutrition, and fluid diet. I think this patient is having a fistula, tracheoesophageal fistula, right? Okay. Sister, let me ask one question. Currently, this patient is on peg feed or nasogastric tube feed?
He is now disturbed. He was on NG feeds, nasogastric feeds. Yeah, nasogastric was he didn't want it, but so there were some issues because we were not sure whether we could stop aspirin and all that because he had some cardiac issue event before that.
Okay.
So to do a peg, there was a problem. So they had not done it, but that time he was NG feeds because he's an independent person. So it was difficult for him to think of that being taken care of and NG feeds. So that's what he just refused to say that he had a problem with the solid. I mean that he couldn't accept that it was coming out through the tracheostomy. When he was drinking, it was coming out through the tracheostomy, but he just couldn't accept that. He said because I mean that was the way.
Oh.
But we put an insert an NG tube for him. We gave NG feeds only.
Okay. So what shall we do for that? He couldn't accept. He had the tracheoesophageal fistula. So we know that, and we put a nasogastric tube for feeding. For that, how can we manage for that part? Any idea? Others, please contribute your thoughts. Did you talk to him, sister?
Yes. Pardon? Yeah.
Yes. Yeah.
Yes, we spoke to him and the family also, like because he has been alone, so the family also didn't know that there was leaking.
Okay.
But anyhow, we had put up NG only few, and we were planning for a peg feed. So at least then he can feed himself. So it was a little difficult for him to accept that, I think.
So how did you find that the patient is having tracheoesophageal fistula?
Because when he was drinking, it came through the tracheostomy. There was fluid coming. And he had removed the inner tube, I think.
Oh, okay.
Because he has sort of neglected a little bit because after the COVID, he had not come to the clinic or stuff. So he had not placed the inner tube again. So then we saw the thing coming out, and then we did the test also, like giving a drink, and then we could see it coming out. Yeah.
So now what is the status, whether he accept or not?
Because I'm in the cardiology, we transferred him to the ENT ward, and then they had transferred to the surgical ward to do a PEG.
Okay.
Yeah, so they wanted to do a gastrostomy. That's what was the final thing.
But because of the cardiac issues, we couldn't do it, right?
Yeah, they were postponing it.
Okay.
That was a plan. They were, because we had to stop aspirin and
Okay. So
yeah.
here we need to educate the patient about that. We need to because now he is not accepting. He is having the tracheoesophageal fistula. Okay.
Yeah.
He is on nasogastric tube. Now we are planning to put a PEC. Okay.
Yeah.
So if he doesn't accept the prognosis, if you do the PEC, also it will be affecting the patient emotionally and psychologically because he is not accepting, no? Because
Yeah.
once he accepts, we can do it if we want. So always you have to keep it in mind the autonomy. We have to respect the patient words. If the patient is not want anything, we don't force. Here, yeah. So for that ethical principles, you have to keep it in mind. Autonomy, beneficence. Beneficence means do good for the patients. Non-beneficence is do no harm. The final, the fourth one is justice. Okay. So here, whenever you plant something for the patients, always you have to think like, is that help? Is that benefit the patients or harm to the patient? So you have to think about that. What are the good things and what are the bad things? And also you have to talk to the family about the force feeding. Because if you feed force, if you feed too much, that will not help the patient. It will help the cancer cell. That important message you have to tell the caregivers first. So food is a symbol of love. They always force the patients to feed. Okay, you feed that like that, you feed that, you always force the caregivers to the patient. Here, if the patient's prognosis is not good, you have to talk to the caregivers first and make them understand. If they are giving nutritious diet, even a good nutritious diet to the patients through nasogastric tube or PEG feed, it will not help to their loved ones. It will help to the cancer cells will grow. So that message you have to convey them, and whenever if they want that they need a food and fluid, but that quantity and the amount, the quantities need less only. So that message you have to convey. And here I think you have to talk to the patient first. Once he accepts only, then you can go for the PEG feed. Otherwise, after PEG, he will again go to the depression. You have to make sure that, and the family support. Here, I always said family is also going through the distress situation. Here, patient is suffering a lot, and also the family members is also suffering a lot because of this problem. Too many problems. It will be affecting them also. So you have to listen their emotions too. If you, they usually the caregivers will tell us to give 1.5 fluid. He is not eating anything. He is not able to eat anything. You can give 1 pint of fluid. You can give, you can put an nasogastric tube feed. These kind of instructions will be there. What you can do is, if that is not helpful, you have to take a family meeting. You can do a family meeting and make them understand that what is the current situation and what are the benefits and what are the bad things. You have to educate the caregivers and make them understand first. Then they will understand. Okay, here also tracheostomy care also is important. We all know that how to do the tracheostomy care part. We learned a lot today. I think that part the rest of the part, you can talk to the patient first, and you can check whether he knows the the esophageal fistula, whether he accepted or not. And once he has accepted, then you can think about the peg feed. Now his age is 74.
74,
And
yeah.
I don't know, is there any metastasis there or not? Is there any metastasis there?
I'm not really sure about that.
Yeah, so if
Yeah.
there is any metastasis there,
Then
it won't help to the
That's
patients. It will suffer. That patients will suffer after the surgery. So then you can think about the symptomatic management and comfort. Any other points you want to discuss? So here, Sony said TPN. Here also, if you do the TPN, total parenteral nutrition also, it will be helpful.
No.
It is not helpful for the patients. It will help to the cancer cells. The cancer cell will grow.
I don't think he'll be happy that way because he wants to be independent and just walk around.
Yeah.
So that's so that won't help him.
Yeah. Okay.
Okay.
If you don't have any questions, we can wind up the session. Thank you so much, Sajan, for the excellent session. Thank you, ma'am, Lila Gandhi, ma'am, for the excellent presentation. Today's the after presentation, the tracheostomy care presentation. Thank you for your contributions. We'll see you next day. Thank you once again.
Yeah.